Assalamu alaikum and good evening, everybody. It gives me pleasure to moderate today's session, which is going to be on acute kidney injury in pregnancy, an extremely important topic, which I'm sure all of us have encountered at some point or another. It gives me pleasure to introduce today's speaker, Professor Ihsan Al Shamma.
شماع
الشم الشماع.
شماع نعم.
Okay, sorry about that. Professor Shamma has a very rich biography, so I will just mention the highlights. He's a consultant nephrologist and kidney transplant physician. He's the founder of the Iraqi Board of Nephrology and, in fact, was the director of the Board of Nephrology as well until 2006. And he has numerous publications in the field of nephrology and transplant. So, Professor Shamma, floor is yours.
Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا على دعوتكم الكريمة لحضور الاجتماع المبارك هذا. Acute kidney injury in pregnancy it is quite a health problem. It's an important health problem. It comprises all the causes of acute renal impairment early in pregnancy up to the 3 months after delivery. It's important obstetric complication because it's associated with significant maternal and fetal morbidity and mortality. Acute kidney injury during pregnancy can be caused by all the disorders we know about acute kidney injury in the general population. However, there are certain pregnancy complications that unique to pregnancy that can cause or be associated with kidney injury. Most reviews estimate that in countries when there is a good antenatal care, approximately 1 in 2,000 pregnancies are affected by acute kidney injury, severe enough to require kidney replacement therapy. The incidence may be higher in countries where the antenatal care is not so good and the settings where for illegal abortions are performed, leading to septic abortions. There has been increasing incidence of pregnancy-related acute kidney injury for several reasons. One of them is the high rate of detection, better rate of detection, and high rate of deliveries in hospitals. Increase in high-risk pregnancies when the mother is a bit old or has one of the comorbidities like chronic kidney disease, hypertension, diabetes, systemic lupus, and also if she's got history of preeclampsia or she's from a low social economic status. High body mass index is another factor, and history of diabetes. Women with diabetes is reported to have more than 4 times higher risk of developing acute renal failure during pregnancy as compared to women without diabetes. What's the etiology? The etiology of acute kidney injury in pregnancy follows a bimodal distribution. There are 2 peaks in these conditions. The first one, the early pregnancy, before the 20th week of pregnancy, the renal causes are more common. This is due to vomiting of hyperemesis gravidarum or septic abortion or infection. On the other hand, in the late pregnancy, after the 20th week of gestation, we've got mainly the preeclampsia with or without fatty liver of pregnancy and the thrombotic angiopathy. Now, acute tubular necrosis or acute cortical necrosis in severe cases can happen due to hemorrhage. Volume depletion typically is due to severe vomiting. Hyperemesis gravidarum is a common cause of pre-renal acute kidney injury, acute juvenile necrosis early in a pregnancy before 20th week of gestation. About infections, pregnant women are more prone to infections because of physiological changes of pregnancy, which cause dilatation of the ureters, and there is altered immunology. And infections can be a cause of acute tubular necrosis. Now, before the 20th week of pregnancy, septic abortion, which was quite common, it is now fortunately much less common than before, although some parts of the world still have high incidence of septic abortion, is a cause of acute tubular necrosis. Acute pyelonephritis increases in the second and third trimesters of pregnancy, and severe pyelonephritis can lead to sepsis-associated acute tubular necrosis. Preeclampsia. Preeclampsia is a leading cause of severe pregnancy-related acute kidney injury. It usually happens after the 20th week of pregnancy and the third trimester and in the postpartum period. Acute kidney injury is more common and severe when preeclampsia is accompanied by the severe HELP syndrome. It accounts for about 3 to 5% of all pregnancies, but it is increased, the risk is increased in ladies with hypertension, diabetes, or chronic kidney disease from any cause, notably lupus nephritis and diabetic nephropathy. Preeclampsia is a leading cause of maternal and fetal death all over the world. And most cases of proteinuria in late pregnancy after the 20th week of gestation are due to preeclampsia. There is a statement that preeclampsia is the most common cause of nephrotic syndrome during pregnancy. Both preeclampsia, the HELP syndrome, and the atypical HUS, hemolytic uremic syndrome, can progress to the postpartum period. What is the cause of eclampsia? Basically, there is defect in placentation or placenta implantation, and maternal susceptibility play a central role in the development of preeclampsia. Now, more recently, the placental-derived angiogenic factors were found to play a role and can be used as a marker of eclampsia, as we can see. If there is an increase in the soluble, like tyrosine kinase 1 factors compared to placental growth factor ratio, if there is increase in this ratio, it indicates usually that the condition is eclampsia, while a normal ratio will virtually exclude eclampsia as a cause of proteinuria or hypertension or acute kidney injury. A lot of changes happen in the preeclampsia, which are against the normal hemodynamics of a normal pregnancy. And these changes lead to decrease, mainly to decreased GFR, and also increased serum uric acid, decrease in renal blood flow, proteinuria, and activation of inflammatory and coagulation cascades with all the complications. One of the features of eclampsia is the volume depletion, contraction of plasma volume, which is bad to the fetus environment. Endotheliosis is a pathological hallmark of eclampsia and preeclampsia. This is typical endotheliosis, swollen endothelial cells, which lead to fall in the GFR and production of vasoconstriction and lead to the long-term dysfunction and persistent impairment of the GFR, endotheliosis. Now, TTP and complement-mediated thrombotic mitoangiography is due to complement activation. It is known that in pregnancy, there is a well-recognized trigger of complement activation occurs in normal pregnancy, and this is exacerbated by eclampsia. So these two conditions are characterized by the presence of thrombi of fibrin or platelets in multiple organs, affecting all organs, particularly the kidney and the brain. And this is the picture of the histopathology of microangiopathy, thrombotic microangiopathy, leading to acute kidney injury, and it has got a bad prognosis. It's difficult to treat and it's got a bad prognosis. Fortunately enough, it's not common. It's rare. It's a rare complication of a pregnancy. It tends to happen late in pregnancy and over to the postpartum period. Another problem with the pregnancy, it can trigger a relapse or new onset glomerular disease. De novo glomerular disease can arise during pregnancy, or a pre-existing glomerular disease, notably lupus nephritis. The pregnancy can trigger these conditions or cause a relapse because of the hyperimmune state of pregnancy due to hormonal effect, notably the high estrogen level. SLE is a problem by itself in pregnancy. SLE, which affects our childbearing woman, doesn't affect infertility. So the good news is that these ladies can conceive, can have pregnancy. But the bad news is that these pregnancies are not planned well, and it happens on the top of active, not well-treated lupus nephritis. There will be a lot of problems. The first problem will be adverse maternal and fetal outcomes, including miscarriages, preterm birth, intrauterine growth restriction, and neonatal loss, neonatal lupus. Also, there is a problem that in lupus nephritis during pregnancy, there is always a risk of a kidney flare. There is always a risk of flare of the lupus nephritis. For example, there is the PROMISE study which showed that if the lady is under complete remission of lupus nephritis, only around 8% will develop a flare during pregnancy. While if the partially treated or not well treated lupus nephritis, the risk rises to around 20%. And this is also attributed to hormonal changes of pregnancy, notably the elevations of estrogen level. Also, lupus nephritis is associated with significant risk of preeclampsia. It is second to diabetic nephropathy in causing or in carrying a risk of a preeclampsia. And what makes the things difficult is that if you've got a flare of lupus nephritis late in pregnancy, after 20th week of gestation, you will have a problem in differentiating lupus nephritis from preeclampsia, which is which. And because late in pregnancy, it happens that lupus nephritis might be associated with normal complement levels. There is increased production of complement during pregnancy by the liver. So the complement levels wouldn't help, can be normal. And sometimes the DNA double standard bodies might be negative. So many things will make differential diagnosis difficult, But in this case, we go to the other features of eclampsia, like elevated uric acid, elevated ratio of the soluble factors of placenta, which point to eclampsia. As you can see from this graph, that with active lupus nephritis, there is increase, very much increase in preterm delivery and labor. While if it is an inactive disease, it's quite much less, near average. And this shows that the rates of preeclampsia and lupus nephritis is second to diabetic nephropathy. Diabetic nephropathy is the most important risk factor among other diseases, chronic kidney diseases, to cause preeclampsia. Another cause of acute kidney injury, fortunately enough, it's rare in these days, is the renal cortical necrosis, acute cortical necrosis. That happens when there is obstetric catastrophe, severe hemorrhage, massive hemorrhage, cardiovascular collapse, hemodynamic instability due to all these complications of pregnancy listed here. This will cause severe ischemic acute necrosis, or in more severe cases, an acute cortical necrosis, which is unfortunately is a severe and often irreversible form of ischemic ATN. One of the causes of renal cortical necrosis is septic abortion. It used to be quite common, but fortunately enough, now it is an uncommon problem in countries where there is good antenatal care, while in some parts of the world it is still a problem. It's characterized by sudden onset of oliguria or total anuria, And this is the picture, the histological picture of acute cortical necrosis, when they see the glomerulus has been completely necrotic with the tubules, and the condition is irreversible, unfortunately, in many cases. And this is the typical scenario. If you have a woman who's got cesarean delivery, and during the past 6 hours, she produced only 100 ml of urine via the urinary catheter, the most likely diagnosis will be renal cortical necrosis. And this is the typical CT image of cortical necrosis, when you can see there is a thin rim of enhancement in the kidneys and the cortex of the kidney. And this is typical of cortical necrosis. Obstructive acute kidney injury is not a common cause of acute injury in pregnancy, but it can happen in the second, third trimester due to compression of the gravid uterus on the ureter. Acute kidney injury in the postpartum period is usually due to atypical hemolytic uremic syndrome, or to the non-steroidal anti-inflammatory drugs which might be given to during pregnancy. What about how we detect acute kidney injury during pregnancy? The first fact is that GFR increases by around 50% during pregnancy, and this will lead to a lower baseline serum creatinine compared with non-pregnant individuals. So if you see a pregnant lady with apparently normal serum creatinine, and it is in fact not normal. It's not normal for her because it should be less than non-pregnant state. And these are the typical hemodynamic changes which should happen during a normal pregnancy, with increased effective renal plasma flow, increased cardiac output, increased expansion of plasma volume, increase in GFR, as we said, by 6%, with lowering of systemic vascular resistance. This is very important. Lowering of systemic vascular resistance, because one of the hallmarks of preeclampsia is vasoconstriction with the increase in vascular resistance. So according to these changes, what will happen is we will have lower blood urea, lower serum creatinine, lower serum uric acid, and these are lower serum sodium. These are normal pregnancy. And this is an old picture, which I love very much, from the 80s. It showed how there is an increase in the effective renal plasma flow and the GFR starting from as early as 6 weeks of gestation. And it is throughout the pregnancy and doesn't fall until, say, at the beginning of the third trimester. Okay? So until now, until today, serum creatinine remains the most effective and cost-effective marker for diagnosis of acute kidney injury during pregnancy. This is a fact. Now, a decrease in serum creatinine is expected in the second trimester because of physiological hyperfiltration, increase in the GFR. Failure to reduce serum creatinine has been associated with adverse pregnancy outcomes for both for the mother and for the child. The correct serum creatinine, which is now adopted by many centers, is 77 micromole per liter. More than that, it is abnormal. It is abnormal. What are the risks associated with acute kidney injury during pregnancy? Lot of them. There is a low birth weight, there is small for gestation age, there is a preterm birth, and there is a lower mean gestational age at delivery, and lower mean birth weight, and increase 3 to 4-fold increase of stillbirth and perinatal deaths as compared to women without pregnancy-related acute kidney injury. Now, there is a recent study from the United States which reported these figures, that there is increase of mortality 13.5 folds, an increase in cardiovascular events 10 times. So acute kidney injury, like chronic kidney disease, is a cardiovascular risk, And acute dialysis is needed by around 10%, 9% of these ladies. And acute kidney injury during pregnancy increases the risk of progression to chronic kidney disease and end-stage kidney disease after delivery. So the story doesn't end with the pregnancy. It might continue to lead to progressive chronic kidney disease. This is the patient I follow from Dhok in Shamal Iraq, Kurdistan, with her attending nephrologist Lana Al-Atrushi. This lady who became pregnant without knowing that she has got small kidneys, chronic kidney disease. So during pregnancy, she presented with hypertension and severe vaginal bleeding because of placenta problem. So she had cesarean section. And then post-delivery, her urine dropped and she has oliguria, and hemodialysis was started for her. Immunological survey was negative, but the echo revealed severe dilated cardiomyopathy. So she was treated for that, and the ultrasound abdomen, as I said, showed small-sized kidneys and increased echogenicity. This was an implant pregnancy. That was a bad pregnancy, which has been on the top of chronic kidney disease. And so she was liable to all these complications. So she was treated with all drugs necessary, plus hemodialysis, ultrafiltration. And then when she was discharged, she was scheduled on hemodialysis 3 times a week. This illustrates many facts that unplanned pregnancy on the top of chronic kidney disease, not knowing that, will lead to a lot of complications. And the second thing which illustrates that acute kidney injury, like a chronic kidney injury, like chronic kidney disease, is a cardiovascular risk. She developed severe cardiomyopathy. Now, how we avoid these things? How we can avoid that a pregnant lady will not develop all these problems, all these complications? The factors that should be available to each lady before she becomes pregnant are 3. And this applies to the native kidneys and to a graft kidney in patients with renal transplant. The lady should have no renal impairment at all at the beginning of pregnancy. She should have normal serum creatinine and blood urea. Her bladder should be well controlled, should be within normal, and she shouldn't have significant proteinuria. Mild proteinuria less than, say, 0.3 might be okay, but more than that, any significant proteinuria will be associated with a risk for the mother and for the fetus and the pregnancy. There was a study presented at the Kidney Week 24, the recent one, by a lady from London, and she was assessing the renal function during pregnancy. The problem was summarized as such, that a deterioration in maternal function is associated with adverse pregnancy outcomes, we know that, and long-term morbidity and mortality to the mother and to her baby. So physiological adaptation is important. Serum creatinine is recommended method to assess kidney function pregnancy, and urea guides the commencement of dialysis. While cystatin C wasn't validated. It was not good enough to measure the renal function during pregnancy. And that was her finding, her conclusion, is that serum creatinine she was more tough, more than 55 micromole at any gestation, lower than previously described in population cohorts, is that the urea, if it is more than these figures, should warrant further assessment, while cystatin C do not reflect physiological changes in GFR, even with no risk factor, and is not likely to be useful for as a useful marker of pregnancy kidney impairment. So it's been dismissed. So we are left only with serum creatinine. This is the graph of cystatin C. As you can see, it doesn't apply or doesn't goes with the physiological changes of GFR during pregnancy. So it is not validated. It's not validated. The reason is said that the cystatin C is produced by the human placenta, and its production varies with trimesters. So it makes it invalid to measure the renal function and impairment throughout pregnancy. This is a very beautiful work which is done in 2019, as you can see, by this author. And this picture shows us that how the sorry for that, and shows how serum creatinine starts to drop early in pregnancy and continues throughout to return back around the third trimester. And this is a typical normal behavior of serum creatinine, which should be there if we expect that pregnancy would be healthy both for the mother and for the child. What about kidney biopsy? This is a dilemma. Kidney biopsies during pregnancy, yes or no? Both of them. It might be yes, it might be no. Because kidney biopsies has been long avoided in pregnancy because of the risk to the mother and the fetus. We might be in trouble with the mother and her family if we do a kidney biopsy and it ends with complication or the loss of the baby. So kidney biopsy is high risk in advanced pregnancies. On the other side, why it is yes, it is essential in the management if there is a problem in the diagnosis. It depends on the patient herself, on the pregnant lady herself. Decision is made whether the result of the biopsy will change the management of the pregnant patient or not. If we know that it will change the management of the pregnant condition, we can go ahead with the biopsy. Otherwise, we should be postponed until after delivery. It's contraindicated in third trimester, finished. There's no doubt about that. Because the risk there will outweigh the benefit of establishing diagnosis so late pregnancy. So it is not allowed to do renal biopsy and not recommended after 30th to 32nd weeks of gestation. It's better than to perform the biopsy after delivery. What are the definite indications of doing kidney biopsy during pregnancy? I would say there are three main. Lupus nephritis. Lupus nephritis, if there is a question of flare of lupus nephritis, or there is doubt whether it is well treated or not, kidney biopsy might be necessary because the appropriate treatment of lupus nephritis is typically guided by pathological features, including WHO class and the activity and the chronicity scores. And if you treat an active lupus nephritis during pregnancy, you might improve the outcome of the mother and the child, and you give more time for pregnancy, you prolong the time of pregnancy. While if it is left untreated, unattended, then you will end with poor results of both pregnancy, the mother, and the child. Primary glomerular diseases, de novo glomerular diseases, which start while the woman is pregnant, not known before. If it develops before the 20th week of gestation, it's not eclampsia. So a biopsy here might be mandated because you can treat the patients with appropriate drugs, prednisolone, calcium urine inhibitors, which are allowed during a pregnancy. And this will improve, as I said, kidney function and the proteinuria and decrease the risk of adverse outcome for the pregnant lady and her child. The third clear indication of kidney biopsy during pregnancy, when you have a kidney transplant patient who develop graft dysfunction, a new onset one, while she is pregnant. So in that case, kidney biopsy might be indicated to treat rejection. Now, this is an example of what I said. This is a case record of a lady in the New England Journal of Medicine in January this year. In January this year, this lady, 35 years old, was admitted for induction of labor at 39 weeks of gestation, quite late. She was found to have a nephrotic range of proteinuria and significant hypoalbuminemia. So new onset proteinuria in pregnancy is a diagnostic challenge and has implication, as I said, for both maternal and fetal health. If the ratio was done for this lady, it wasn't done. If a low ratio was found, would suggest that preeclampsia was not the cause of nephrotic syndrome. In that case, biopsy is indicated. But because it's advanced week of gestation, the lady was have induction of labor, and biopsy was done after that, and it shows focal segmental GN and de novo glomerular disease, which starts during pregnancy and warrants kidney biopsy to give specific therapy. But it wasn't done during pregnancy because of the late week of gestation, 39. It was done after induction of labor, and the lady was treated accordingly for her focal segmental GN. Another example, this lady was presented at the Kidney Week 24. She has SLE. SLE, which has been there and was well treated, but later on she got married and she decided to have a baby while she still have a proteinuria. We still have a proteinuria. The first biopsy before she became pregnant was lupus nephritis class 4. As you can see, diffuse glomerular disease and full house immunofluorescent, all indicative of class 4 lupus nephritis, and was treated correctly according to this biopsy. When she became pregnant, or she wants to become pregnant, she was planning to become pregnant, what are we going to do? She still have a proteinuria between 600 and 800 milligram, which is a bit high. Although serum complements were normal, although she has declining double-strand DNA, but the attending physician nephrologist, she decided to do a renal biopsy because she's worried that in case she will become pregnant, she will have a flare-up or she has adverse effects. So the biopsy was done, shows this time a class 2 lupus nephritis. Class 2 lupus nephritis, mesangial proliferative, and sclerosing GN. Then it was between class 2 and class 3. Yeah, with evidence of chronic changes, as you can see in the renal tissue. But the immunofluorescence is better than before. She has IgG only and faint C1q, or probably is considered negative. So how we treat patients and manage patients with acute kidney injury during pregnancy. General measures which apply to all patients. We should identify the cause of the kidney injury. We should start with intravenous fluid resuscitation if the lady is volume depleted because of vomiting. timely initiation of dialysis if needed, prompt delivery of the fetus if necessary in case of severe preeclampsia, plus minus HELP syndrome and TMA. And the management of acute kidney injury, not in doubt, should be a multidisciplinary team. It consists of nephrologists, obstetricians, and specialists in neonatal. This is just to summarize the treatment of various complications during pregnancy, hyperemesis gravidarum prerenal causes, treatment by hydration to restore the blood pressure. Septic abortion or UTI, proper antibiotics, avoiding the nephrotoxic ones and the one which affect pregnancy. Preeclampsia plus minus HELP syndrome, prompt delivery. Delivery is the only treatment of severe preeclampsia. TTP, plasma exchange, and the B-cell depleting rituximab. Atypical hemolytic syndrome, the anti-complement eculizumab has been tried and claimed to be successful in treating atypical hemolytic uremic syndrome, which is usually, fortunately enough, happens more in a postpartum period. Obstructive uropathy, as you know, analgesic and stent nephrostomy. Hemorrhage corrected by bleeding or delivery. GN treated specifically by steroids and immunosuppressives. Early dialysis in a pregnancy. This is now adopted by many centers, that when you decide when dialysis is indicated, you should start early. It's not like dialysis in non-pregnant ladies where we are concerned that intensive dialysis or early dialysis might lead to loss of renal function, and we have to wait and to give it more time. Because early initiation of dialysis in a pregnancy will improve fetal outcomes, improve birth weights, gestation age in women with kidney failure. To start dialysis earlier than in pregnant patients when blood urine nitrogen is more 42 milligram, despite volume restoration. Because uremic environment is bad for the fetus. It has a negative effect on the fetal survival. So the message in a pregnancy, early dialysis rather than late. Low-dose aspirin, we all know, should be started for ladies to prevent a preeclampsia, should be started early enough, between 12 and 16 weeks, and not later than 20th week of gestation. Urgent delivery is indicated when there is preeclampsia with severe features, plus minus HELP syndrome, which you all know consists of hemolysis, elevated liver enzymes, low platelets. Individuals who develop preeclampsia might be increased risk of developing end-stage kidney disease later in life. Use of intravenous magnesium is still a standard of treatment for the prevention of seizures in patients with preeclampsia. But as magnesium is renally excreted, women with moderate or severe pregnancy-related acute kidney injury are at a risk of magnesium toxicity, so the dose should be adjusted. As regards lupus nephritis, it's a problem because the green drugs are allowed during pregnancy. There's no problem of giving azathioprine or moderate dose of prednisolone, cyclosporine, and tacrolimus, considered fairly safe. Hydroxychloroquine should be given to all patients with lupus, particularly throughout pregnancy, because it's reported to help to prevent lupus flare. While the red drugs are contraindicated because of teratogenicity. MMF, diflunomide, methotrexate, volcosporin, cyclophosphamide, and angiotensin inhibitors. So all these are contraindicating, should be stopped at least 6 months before the pregnancy. And even leflunomide said should be stopped long before that, 24 months. While the black drugs, these are biologic. Our new biologic drugs like rituximab, belimumab, these are still in doubt. They are labeled as C, which means there is no adequate studies in humans, and need further, we wait further to see whether these are accepted during a pregnancy or not. The risk of rituximab is a good drug, B-cell depletion, but if it is given during the second, third trimester, it has been associated with hypogammaglobulinemia in the neonate, which is not good. What about the outcome? The outcome of acute kidney injury in pregnancy, alhamdulillah, is not bad. In the short term, around up to 76% will have complete renal recovery. Partial renal recovery will be seen around 16%. Unfortunately, some succumb because of acute kidney injury in severe cases. Preeclampsia. Before we used to think that once the mother is delivered, eclampsia will finish with the delivery of the baby and the placenta, and everything will go back to normal. Current evidence says that this is not true in every case. In many patients, proteinuria, yes, might resolve by 6 to 8 weeks after delivery. But for some patients, hypertension and other manifestations of chronic diseases recur. Therefore, it's recommended that after an episode of preeclampsia, continuous follow-up and screening is warranted. And as we said, that history of preeclampsia in one pregnancy means a preeclampsia in the next one. So it's a risk for the coming pregnancies. What about the poor outcomes? Why we get poor outcomes? So that not to get poor outcomes, and blamed by the people, we should avoid these red things. Inadequate initial station. التقصير في إعطاء الفلويدز during the early period because of vomiting. Late initiation of antibiotics. We hesitate to give antibiotics. We shouldn't do that during pregnancy. Prolonged intervals, we take time in order to reach to the diagnosis, which is quite bad. Delayed initiation of dialysis, as I said. Late dialysis is bad in pregnancy. Early dialysis is the rule. And many patients with renal cortical necrosis who require dialysis will not recover, unfortunately, their kidney function, and they end with regular dialysis. So, in our conclusions, the rates of pregnancy-related acute kidney injury have increased in recent decades for many reasons. Acute kidney injury continues to remain a frequent complication and health problem of pregnancy. Pregnancy-related acute kidney injury is associated with high maternal mortality and adverse maternal and fetal outcomes. Regular monitoring of kidney function should be done by the kidney health providers during pregnancy, especially in women who are at high risk. Since diagnosis of acute injury during pregnancy may not be straightforward, clinical judgment should be used to identify the acute kidney injury promptly and initiate appropriate therapy to optimize recovery. Pregnancy-related acute kidney injury requires a multidisciplinary team, as we said, for the best practice and to improve the outcome of the mother and the fetus. Pregnancy-related acute kidney injury continues to remain under-recognized and therefore needs continued exploration to ensure that long-lasting effects, including development of chronic kidney disease and the need for kidney replacement therapy, are minimized. And thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله وبركاته.
وعليكم السلام.